Research is going to go first, so if you come on up, and we'll get the reports. There we go, research networks.
Go ahead. Come on, get up here. All right. Okay. We're tag teaming. All right. So I'm Mike Stoner. For those that haven't met me yet, this is Prashant Mahajong.
Hi.
For those that haven't met him. So just a little background. I think most of the breakout groups did this pretty similarly, but how we did it, before this conference, we kind of broke down, had our big, large topics. So we took those four large topics, and we broke up into 4 tables. So mostly equal groups. There were 40 participants who came in. We had some of our leaders at each table and broke the tables down into our topics, which were organization, technology, knowledge translation, and then clinical topics. Like I said, with that group, we had some of our leaders go into those. At the tables, we brought in what we had from before, our pre-conference survey, our pre-conference Delphi. We just presented that information up for our participants. From there, they were able to take that, change it, add to it, edit it, however they wanted to, and come up with the list that they liked. So because they were all broken into quarters, of course, we wanted the whole group to be able to add to said information. So at that point, they broke up again, and were able to go around the room and add with sticky notes, as you see around the room, any sticky notes, any more information they wanted to put on to that specific theme or category. From there, the ranking process started, and we got innovative and used sticky notes. You know, it's the 21st century. We got little stickers, and people were able to say, hey, I like this, I'm giving it a sticker. I like it really good, I'm going to give it 2 stickers. And they were able to rate it from there. And that's where we got information. So let's give you the info. First off, knowledge translation. So for all 4 of these, for knowledge translation, technology, and the organizational topics, we gave it top 5. For the clinical topics, Prashant will go over that, we gave it top 10 because there were a lot more of those categories. So I'll give you the information first and kind of show you how it fell out. So from knowledge translation, we had dissemination and implementation of evidence-based practice, changing provider behavior, motivations, and metrics, how to identify topics for knowledge translation, and then the science behind knowledge translation, and then finally how to use shared decision-making. And if you look at that, you know, towards the last, number 4, number 5 kind of fell off, but the top 3 were pretty close together. These are number of dots. Moving on, organization. Dr. Cooperman manned this one all by himself as a leader. There were a lot of people in the group. Acceptability, barriers to reporting clinical data, building diverse registries, collaboration between the peds emergency medicine folks, the EMS, and then, how did the work group mention it? It was not adult EDs, but kind of general EDs that don't see as many pediatric patients. And then dissemination of that information. Next, best use of the resources within and between networks, validation versus divide and conquer. So do we take the information like, the 3 different head injury rules, or do we need to divide, conquer, and then not keep redoing the same study? Number 4, global identification of the top 5 questions, collaboration, and to answer those questions. And then finally, research into exemption of informed consent for the time-sensitive ones. The seizure study is a great example of that. So, the first 2 were about even, and then they kind of petered off after that, but they all had a good dot number. And then technology. So this was a good group. People were trying to figure out how to use technology. We had some POCUS, or point-of-care ultrasound. We had the electronic health record. Telemedicine was thrown in there. Simulation was thrown in there. And this is how it all kind of came down. People liked using the EHR, EMR for predictive analytics. They liked the machine learning. And I think, Mark, how did you explain that? No. I think somebody was mentioning having the machine figure out, identify, like an ultrasound, what it's seeing. Telemedicine, provider to provider. They mentioned using telemedicine, like talking like doc in a box or doc on a phone, but they're not like that. It's more provider to provider, getting the peds emergency medicine expertise out to the group. Simulation training, and then finally using the electronic health record for decision support, kind of helping make your decision. I think Dr. Cooperman had a good example of that with the head injury stuff this morning. And these are pretty even. Most people they were all kind of right along the same line.
So this is some good news and bad news. So the good news is that the first 3 topics which we had done 3 rounds of Delphi sort of fell in the same, largely in the same buckets as the big group. So that was the cleaner portion. But the 4th group was the clinical topics. And interestingly enough, it has gone through 3 rounds of Delphi with the group of experts of 21, and some clinical topics had dropped off and some retained. So we had got this to the group. Plus, this group also had an opportunity to give us some suggestions as to what topics might be beneficial or might be useful for or amenable for global research. So what ended up happening is a set of new topics did enter in this group. So the bad news is that the group of 21 is going to have to do another round of Delphi. And what we're going to eventually do, and I'll give the results, but what we're going to probably do is break these down into topics that are disease specific and topics that are process specific, like say shared decision making or PEDS patients in adult EDs. And then have this final round of ranking before we give out those results. But I just wanted to show what these results showed is that the PEDS patients in adult EDs just rose up. This is based on the number of dots that were assigned, so those got the highest. Sepsis got quite a few dots, and I was trying to hold Fran back desperately, but she was taking, no, but she stayed within her limit of 3 dots per topic. But a few other topics that had originally dropped out now came back in again, and some of them seems appropriate, like cardiac arrest and resuscitation research, which is amenable for global type of approach. And some of the rest are, as you can see on this list. So the final conclusion on this one is, it was a broad spread, is that one more round of Delphi for these broken down into process versus diseases. And once that comes together, then we'll be able to bring this all together as the final results, right? Nate or anyone else has any other thoughts on this one? Okay, that's it. So interestingly enough, it didn't come up amongst the top, but there was a sort of an explanation, like one thought was that the decision rules and a few other items, there is enough knowledge has been generated, so people may not have ranked it that high. But we also had a specific question in TBI, or injury, not TBI specifically, about trials on interventions, specific interventions for specific injuries. But somehow that still didn't bubble up. So the hope is that when we go to the 4th round of Delphi, when we separate them out as process versus disease, we'll see how it comes up. Oh yeah. Super scribe, yeah. Super brain scribe, yeah. Mm-hmm.
We would not have this data if not for
yeah. All the slides.
Hotel room.
All the slides. Thanks.
Education committee.
So education, you guys want to come up? I think it's better if you hold this thing. I'm going to let you do that instead of having it hang out.
Okay. So education took a slightly different approach. We're going to start by thanking everyone, not only our subcommittee members who have worked over the past year and a half, along with Maybelle and I, to generate ideas, themes, and get things launched, but also our patient advocate, Troy Denslow, who helped to weigh in many times and keep us anchored in what this is all about. The scribes who tolerated all the discussion today and got it all committed, on computer, as well as the many attendees, who we hope to link back with to keep the spirit and the momentum going after the conference. We also had some folks who participated pre-conference but were unable to make it today, and none of it's possible without Paul and Kurt helping to guide us. So a thanks to you. Okay, we were charged with making the case for future peds emergency medicine education research and scholarship, what is needed. A nice narrow topic, took us no time at all. So we spent the past period of time leading up to what were ideas that then joined with our ideas that were generated in the initially. So we had our initial ideas plus what came up in the pre-conference survey that then served as the basis for our conversation today, our discussion. And that came from assessment of gaps, which was translated into themes. Our core themes were 4: disparities in core education, integrating the patient experience into peds emergency medicine education. How would we do that? What would we want? What would it mean for the future? Aligning across providers, the many different providers that have different education needs, yet it all comes together in some core concepts. And is it possible to think about education research networks? What would they look like? What is needed? How would we launch them? So in our session, we teed off just agreeing with where we were going, and then broke into 2 discussion groups. Discussion group 1 covered the first 2 topics in discussion and in using sticky notes back and forth for additional ideas to keep the flow of discussion going. And then the second group looked at the second 2 themes. Is that about it? Yep. And then we came back together, reported out to each other, added a few ideas, and closed our consensus. When we launched, we acknowledged a whole lot of barriers that exist in terms of education. And top of the list for those barriers is what was mentioned earlier today, the many silos that exist. 4 organizations, 2 for EM and 2 for pediatrics, nominally, as we just scratch the tip of the iceberg, to look at what needs to come together to truly achieve a consensus and a new direction to unify and come up with directions for peds emergency medicine education. Also, this is about what funding for education looks like. We'll ask you all to just put a coin in the jar as you leave. That'll be very helpful to our effort. But certainly thinking about how do we then reframe and truly seek out funding to move forward peds emergency medicine education research so that it can be meaningful and be in the forefront. And our assumption was that we want to achieve a unified vision for peds emergency medicine education, that we could hopefully not only foster a core concept of core content that's important across providers, both for core education as well as ongoing education, but joining with efforts like the one you heard about just in the talk before to really be effective, whether it's through simulation or you name it, be effective in moving the needle on this. So now we'll have the report out results.
So again, we had 4 groups, and we'll just be reading through these because there is a lot on these slides. But for our disparities in core education group, it really covered the gamut because we have a wide spectrum of practitioners that take care of children. So what we need for our research and scholarship priorities are consistent and vetted, peer-reviewed, if you like, dissemination of not only content and resources. So this content is everything that's available in terms of educational content, from online to printed material. We also need to establish a continuum of core education that can span a spectrum of providers, so that, for instance, you might have a unified curriculum that patients in urgent care settings, you know, when you reach a certain level of care, then you need to escalate. But everybody should be on the same playing field as far as medical knowledge. And then the best evidence needs to be curated, and especially the free open access content needs to be accessible and quality peer-reviewed. The outcomes, we would like to establish core content, what minimum standard there is for the groups. We need to survey changes in providers' level of comfort post-interventions. This will require reviewing improvements in QI metrics and then online outcomes, completion of online modules or QBank results or things like that. And then for next steps, determining areas of focus study, needs assessment, and selecting those key outcomes. For integrating the patient experience, this is really what today has been about. The lunchtime session drove this point home. Our research and scholarship priorities are to establish communication patterns with patients. We need to discover what practices are used to communicate care to patients and families and explore those communication gaps between the various settings in which patients receive their care. Important outcomes will be to see what hospital use patterns are, where patients are going to perceive they are going to receive good care. And as we said, we should be able to take care of a laceration and not have to drive 45 minutes for that care. Patient survey for feedback on experience will be needed on a large scale, and also a standardized schema for patient care interactions to be disseminated. So we do need to perform another needs assessment and of patient perceptions of their care experience. The third group was alignment across providers. For that, again, for research and scholarship, we need to have a needs assessment to see what gaps in variation in care occur between the disciplines. And we have such a broad group of practitioners that spans beyond physicians. We've got nurses, PAs, APPs, allied health, EMS, you name it. And so what sources do various providers use for their medical knowledge? We need to define a common standard across disciplines, what standards are appropriate for various settings. Again, this is sort of reiterating who will be the stakeholders and actually own this standard of care. And in determining how to disseminate that, unifying accessible resource, none of us can move to Canada, and then making sure that the type of education is appropriate for the type of provider. So hands-on, readable modules, etc. The outcomes here, we want uniform, consistent care between providers and settings for similar presentations, and we also need sustained improvement in provider knowledge of defined clinical problems beyond core training. So our next steps, again, identify stakeholders and create buy-in from the relevant disciplines, create and perform large-scale needs assessments, and prototype a scalable educational resource. Then lastly, research and scholarship priorities for research networks. Well, we need to identify common diagnoses for which gaps in education impacts on costs. For example, unnecessary transfers, unnecessary testing, unnecessary treatments. Establish best education practices for dissemination of research and innovation, and promote buy-in from institutions and organizations. And I think we can do that with cost saving that could occur. And then evaluate the EMR as a means to power educational tools, for example, incorporating clinical decision rules. So outcomes would be to demonstrate revenue loss from lack of consistent core and ongoing training, identify index or common problems highlighting educational disparities, and targeting funding options from state and community sources, and finally evaluate pathways for implementation. So our next steps, we need to create a ruckus as to the extent of this problem. And here we could really turn to our patient advocates for help. We need to demonstrate the benefits achieved by unified education, and then partner with existing networks, PCON or PERN, and maybe create an education arm. Anyway.
No pressure. Last, we recognized, breathe. We recognize that we need a commitment to change. I think for all of us, I think it pertains to the whole consensus conference in so many important ways, but particularly for education. It is astounding. I thought my voice would carry. I'm sorry. It is astounding that despite a lot of information that's out there, we still have education gaps. I think what you described is so pivotal and so important, and just taking us in right directions, yet still we know those gaps are going to be there. And so how we can best angle to meet the need, I think speaks strongly towards collaboration. And so our group recognized that part of our commitment to change is not only the core group that we had today, but hopefully to grow from those collaborations through our U.S. national organizations, and then hopefully partnering with international partners to really move this forward. And that's how we ended our piece. Thank you.
So, you talked about funding. Did you guys have a chance to talk about strategies for that at all?
You wanted to? Yes.
So there's a loaded question. I think one of our, what was a joy today was bringing all the people here together. And what was one of the things that we needed was more time, because this is really scratching only the tip of the iceberg, so we couldn't get in depth into funding, and I think that speaks to the patient advocacy piece, and really this needs to be a groundswell. So that's our thoughts, but we need to obviously look into it more.
I think you had mentioned, Kurt, about thinking about local funding, state and local funding that may fuel some education efforts if there are particular gaps in regions that is certainly very important. I think we're going to need to think more broadly in terms of foundations and other things and how we create that sense of need. One idea that was floated in our group was potentially as the big companies whose names might make you shudder as you type your chart, but big companies who might be involved, might be interested, who hold EMRs, be interested in having clinical decision rules and other things piloted, educational initiatives piloted through their EMR. I don't know if that's a direction we should go. I think that's ethically charged a little bit, but that did come up for us as well. And we would welcome from the group any additional suggestions. Thank you.
Okay. Thank you. So we do have a few people that are from funding agencies here who are paying attention. So it isn't necessarily impossible that you might be able to capture some support, especially at the state level.